All right. Good morning, everyone. Can you hear me okay? Excellent. And also thanks to the people online. I have to say, it's so nice to be in California. As soon as I landed, the sun was shining, everybody was smiling. It's really nice to be out here. And it's an honor to get to present at Medicine Grand Rounds. I understand this is the biggest department at Stanford, certainly the best department, I would assume. And I'm excited to get to represent both medicine and public health this morning. So, with that, my job as health commissioner has been both fascinating and challenging. I've been the acting health commissioner for about 7 months now in New York City, and it's really interesting from my perspective to kind of see a broader aperture than what I had been looking at previously, really focusing in the health equity division within the health department. In particular, understanding all kinds of new things about our mental health programs, all kinds of new things about our infectious disease programs, our restaurant inspection programs. So it's been a real incredible journey and also a very challenging one in my short 7 months as acting commissioner. But my role, of course, is as the city's doctor, which is a pretty cool role to play for the biggest city in the country. And we think, of course, about everything on a population level. While I also do see patients at Kings County Hospital as a hospitalist, as was mentioned. But again, representing both healthcare and public health is not easy. Sometimes the two fields can feel incredibly distinct, different, not connected. And that separation, I think, does a disservice to both fields in many ways. I think the closer that we can bring our fields, and part of what I was hired to do when I became the inaugural chief medical officer, bridging public health and healthcare, is so important, particularly in times like these, where public health and healthcare are both under attack in the way that they are. From my perspective, also, public health is about health equity. That is something that has always been a part of my approach to medicine, to public health, to all of my work. And I'm going to talk quite a bit about that today. So let me start with let's see, I forgot to ask how to control the slides. Do I just use the arrow? I should have asked that part. Oh, got it. Thank you. Perfect. It always goes wrong when it's timed. No problem. Oh, is that? I can just do the arrow. Yeah, that's fine. Thank you. Appreciate it. All right, back on track. So I always like to start a little bit with kind of my background and how I come to this work. I grew up in West Philadelphia. Some of you may be familiar with Philly or have lived or spent time there or trained there. In Philly, the life expectancy for Black men in West Philly is 65 years. That's about 7 years below the life expectancy for Black men in New York City, where I'm currently based. And Black men in New York City also have the lowest lifespan of any demographic group in either city. 65 is a shockingly low number. It's, from a personal perspective, kind of a little bit of what I got to see growing up, because my dad runs our family's funeral home and has been running that funeral home for 3 generations. And as a kid, of course, it was pretty obvious to me who was being buried. There were clearly far more people of color who were dying young. And that's kind of one of the earliest memories I have of understanding the patterns of who our society values. Those patterns are unfortunately not new, and neither are our attempts to interrupt them. And in the New York City Health Department, one of our big goals is to raise life expectancy to its highest level ever, 83 years by 2030, partially in response to the incredibly unfair, inequitable, and generally widespread loss of life expectancy during the pandemic that we all just experienced. So inequity, of course, is not unique to Philadelphia, to New York, or any other place in the country. Right here, San Mateo County has a similar goal to end or at least ease racial inequity in life expectancy. This county is consistently ranked as one of the healthiest in the state and the country, but Black residents in San Mateo County have a life expectancy that's 7.5 years below that of their white neighbors. There's no currency more valuable than time, and we're doing all we can to give everyone more time with the people they love. I see this work as a continuation of the practice of social epidemiology that began with W.B. Du Bois in my hometown. In his seminal work, The Philadelphia Negro, Du Bois blamed the inequitable health outcomes squarely on the shoulders of a larger society that abandoned their responsibility to Black Americans. In 1899, 125 years ago, 26 years ago, he wrote, "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." More than a century later, we're still living under the weight of that indifference. We're watching as its consequences play out in New York City today. And of course, kind of part of the reason I'm here is to talk about how we can move from indifference to reparative action. All of us have a role to play in that movement. But before we can do that, we have to understand that we're all working within a health landscape that is profoundly shaped by structural racism. And in New York City, we literally can map these inequities across the 5 boroughs. New York operates as a collection of unique neighborhoods with a lot of different resources, different challenges, different contexts, different languages, and patients are often carrying the weight of structural inequity. The maps that I'm going to show you today show nothing about individual faults or the failures of people. Instead, they really reflect the consequences of systems and structures that consistently prioritize some communities over others. So let's get going. I have to bring my heat maps because I wouldn't be a good public health person if I didn't do so. On the left is a map of poverty in New York City. The dark greens and blues represent neighborhoods with greater proportions of people living below the federal poverty level. That metric has not kept up with the true cost of living and represents a very extreme level of poverty. In 2025, the federal poverty level for a family of 4 was just over $32,000 a year. Next to this poverty map are the maps of the percent of Black and Hispanic residents in New York City. High poverty neighborhoods clearly overlap with mostly Black and Hispanic neighborhoods. And we see specifically in central Brooklyn, which encompasses several majority Black neighborhoods, and the mainly Hispanic neighborhoods of Upper Manhattan and the Bronx show up as the most impoverished parts of the city. Let's see if I can make this work. Does this work? No, that's okay. But you get the idea. So we've created a society where race and class are closely related. That's not news. And since the founding of the United States, we've exhibited a real deep indifference toward the well-being of Black and Indigenous and other people of color in this country. The consequences of that indifference are embedded in many political and economic systems that shape health and healthcare, and they're on full display, as you see here in New York City today. At the health department, we're focused on how these maps overlay, of course, with health factors, health risks, health outcomes. So let's look at that a little bit more closely. One of the major risk factors is housing insecurity. And New York, of course, is known for its incredibly unaffordable housing market. Very, very crazy. You guys have that problem too, I understand. In neighborhoods where a significant portion of residents fall below the federal poverty level, we see a greater frequency of court-ordered evictions. So safe and stable housing, of course, being a basic human need and a requirement for health, is obvious. And again, the baseline condition from which many other health interventions can grow is stable housing. And of course, another one, food insecurity. This is the same pattern over and over again. Residents of poorer, majority Black and Hispanic neighborhoods are more frequently worried about being able to afford enough food for their households. And the darkest blue neighborhoods indicate areas where more than half of residents are food insecure. This is happening in the richest city, in the richest country in the world. We're surrounded by an immense level of wealth that remains densely concentrated among an increasingly thin slice of the population. Particularly when it comes to poverty, these are actually conservative figures. Poverty in New York City is probably more accurately captured by metrics that take the high cost of living into account, and the federal poverty level does not do that. Robin Hood Foundation is a big foundation in New York City that looks at poverty. They just released their estimates for poverty in New York City for this year. And in 2025, they found that the city's overall poverty rate is 25%, nearly double the national poverty rate of 13%. 1 in 4 New Yorkers live in poverty. And at the same time, 110 New York billionaires are worth a collective $694 billion. And New York City is home to more billionaires than anywhere in the world. And more than 2 million New Yorkers can't afford to meet their basic needs. So it's a privatized healthcare system, and millions of people are dependent on what is an increasingly fraying social safety net for medical care and for their social needs. What's in the news right now with Medicaid, I know, is incredibly troubling to you all here, although it sounds like you need to expand accepting Medicaid at Stanford. There are half of New Yorkers on Medicaid. More than half of the births in our city are to mothers on Medicaid, and 60% of our kids are on Medicaid in New York City. So when you see it all mapped out like this, of course, it makes me think again about the structural inequities that we're still dealing with in 2025. So let's keep going with more maps. I promise there's going to be some highlights and happy parts to my talk, but we're not there yet. Perhaps the greatest offense of the crime that is a system that distributes resources unfairly is that it also distributes time unfairly. The consequences of these inequities are taking years off of New Yorkers' collective lives. This is a map of the premature death rate, which is death before the age of 65 in New York City. Once again, we see the most impoverished neighborhoods with the highest proportion of Black and Hispanic residents are the most affected areas. The blue outlines on this map represent areas served by our neighborhood health action centers at the health department, which were developed under Dr. Mary Bassett, our former commissioner. These are brick and mortar centers that are strategically located in priority zip codes. Our attempt was to really build out our physical presence to better serve communities that have historically been abandoned and sometimes even directly harmed by government policies and systems. So this is our place-based approach to health equity, which you hear a lot of public health people talk about. But let's take a step back and figure out how we got here. If we're to stack every single map I just showed you on top of each other, the overlapping areas of impact become very clear. They mimic the boundaries of historically redlined communities in New York City. Our political and economic decisions have compounded over decades, and we've created a reality where resources are so stratified that New Yorkers in one neighborhood can expect to live more than 10 years longer than residents of another. All of these maps of race, poverty, food insecurity, housing insecurity, premature death, and more are again the results of policies and practices that we've created. These are human created, some would say man-made. They don't have to look this way forever. At the New York City Health Department, we're driving resources according to need. We're determined to improve health outcomes citywide, but we're prioritizing the areas that have been treated the most unfairly. We protect the health of more than 8.5 million New Yorkers, and we have more than 7,000 employees in our New York City Health Department. So you can imagine we have a lot of work to do based on all of those maps. I wanted to just share a little bit about what we do in the New York City Health Department. So to support parents who are pregnant or have young children, we've provided more than 20,000 families with nurses and doulas each year. To prevent foodborne illnesses, we inspect over 30,000 food service locations for food safety, including restaurants, cafeterias, and food trucks, which you've probably experienced if you've come to New York City. To inform our approach to public health interventions, we include more than 200,000 New Yorkers in our surveys every year. And then to ensure that every child in New York City has access to vaccines, we distribute over 2.5 million doses of pediatric vaccines to more than 1,300 healthcare providers across the city. To prevent overdose deaths, we distribute about 300,000 naloxone kits, 54,000 fentanyl test strips. And to meet New Yorkers where they are and build trust in priority communities, we've equipped more than 5,000 community health workers to join our public health corps. That's just a glimpse of our day-to-day work. This is what I would like to call public health in action. And while it does encompass healthcare, it operates as a unique and distinct field. The real work of public health happens in communities outside of clinical settings. In the US, it makes up a tiny fraction of our approach to health. Federal funding for public health accounts for less than 1% of total health expenditures. Even still, this current federal administration has proposed cutting funding for the CDC, which distributes funding to state and local health departments, by half. These are relatively few dollars that have an enormous economic impact. Public health funding goes to upstream interventions that prevent down the line healthcare costs. In this field, our greatest successes are crises averted, which can make this story a hard one to tell. But perhaps the most important large-scale metric in public health is life expectancy of the population we serve. And that's our focus right now in New York City, where we're trying to extend life expectancy through our Healthy NYC campaign. This is our most recent data on life expectancy by race and ethnicity in New York City. We're aiming to increase citywide life expectancy to its highest level ever, 83 years by 2030. This data shows that on the one hand, we're on our way to achieving that goal. We've recovered a significant amount of time we lost in the pandemic. On the other hand, we've maintained the long-standing racial inequity in lifespan. Across almost every cause of death, Black and Hispanic New Yorkers are dying sooner than their white counterparts and Asian counterparts. Citywide, Black New Yorkers are still dying more than 5 years earlier than white New Yorkers. But let's spend a little bit of time on some good news again. We are gaining back years lost, largely because the COVID-related mortality rates have dropped so dramatically in recent years, and that's a huge success. You guys as clinicians, I'm sure, have seen dramatic changes in who's coming into the hospital with COVID, and hopefully very few people losing their lives because of it. New York City, as you know, was an early epicenter of the pandemic. And some of you, I understand, were remote volunteers to help our hospital systems triage patients and families when New Yorkers and doctors were underwater. You know how hard it was. We've come a very long way since the spring of 2020. From 2021 to 2022, we saw a 48% decrease in the COVID death rate. So we're on our way to surpass our goal of decreasing COVID-related mortality by 60% by 2030. That drop is in and of itself, again, just a tremendous victory. But what stands out to me is that overall numbers have declined and the racial inequity in the rate of mortality between racial groups has narrowed significantly. Racial inequity in COVID deaths is now almost gone. And it is one of the big drivers of mortality, or was. COVID, in my opinion, is our proof point that we can make meaningful and rapid change, especially in racial inequities, when we have the political will to take a cross-sector approach, invest in public health, and again, advance racial equity. This is the evidence that we can do that when we want to. There are other areas, however, where death rates are climbing. Overdose deaths more than doubled from 2019 to 2022, and that uptick has been especially steep for Black and Hispanic New Yorkers. To me, what puts the gravity of this trend into perspective is just how much overdose deaths have climbed the ranks as a cause of death. In the last decade or so, they've become the leading cause of death in New York City, whereas in 2010, overdoses were the 10th leading cause of death. In 2020, they were 6th, and in 2022, they were 4th. So we're clearly facing a crisis that's dramatically worsened in recent years, and especially amongst Black and Hispanic communities. The increased isolation imposed by the pandemic and the influx of often undetected fentanyl in the drug supply have had really devastating effects in New York City. Over 80% of fatal overdoses in New York City involve fentanyl in 2022. And the racial inequities in these deaths are a clear consequence of long-term disinvestment. While our overdose prevention efforts are citywide, they focus on the communities that are the most impacted. We're working to make naloxone and fentanyl test strips more widely available, as I mentioned. We're expanding our harm reduction programs, and we're partnering with a number of community-based organizations in high-need areas to support the full continuum of care, especially getting people on medically assisted treatment. Perhaps the most important thing these data can show us are some of the pain points in our city's health. These numbers illuminate the issues in communities we owe our care, our attention, and our resources. And it's up to us, of course, to listen and act. So what does that look like? That reality informed the first big project that I helped to lead when I joined the New York City Health Department in February of 2021, declaring racism a public health crisis in a Board of Health resolution. One line worth highlighting here is, whereas racism is a race-explicit system, and anti-racism requires race-explicit strategies, one of the most horrible consequences of racism in a capitalist society is the stratification of resources. Our race explicit strategies have to also be class explicit. Our work at the health department is grounded in both anti-racism and an anti-poverty agenda, and the two go hand in hand based on everything I've shown. So let's talk about that a little bit more specifically. This is what the distribution of wealth looks like by race across the United States. The typical white family holds more than 6 times the wealth of the typical Black family, and closing the racial wealth gap and transforming its effects on public health will take many, many strategies at once. It will take bold policy interventions like baby bonds and universal health care. It'll take making wealth and health data collection and analysis a core public health function. And just as an aside, that's not currently happening. I know that everyone kind of tends to assume that in public health departments, we're always looking at lots of different socioeconomic factors and data points, but we have never collected wealth data in the New York City Health Department. And there's a rising movement amongst economists and health justice people to really look more closely at wealth and how wealth is related to health outcomes and not just income. And the difference is important. So income, of course, is kind of your annual income, whereas wealth is assets minus debt. And when you look at assets minus debt, it is a completely different indicator than income. And it tracks with health outcomes in a very unique and interesting way that we're all still trying to understand. So we're doing a big project at the New York City Health Department right now, actually, to make wealth one of our standard points of data collection, in addition to income, which is very exciting. It'll also take increased community ownership over the methods of healthcare delivery, which are overwhelmingly privatized. These are big changes, but they're possible. And nothing about the inequities I've described is accidental or natural or normal. These are inequities that have been engineered by systems that created, preserved, and exacerbated social stratification for centuries. We built those systems, and we can also dismantle them and design something new. I know it might seem out of touch to talk about these kinds of large-scale solutions that have been politically out of reach for generations, but the past few months have been some of the most challenging for public health and public service in recent history. We're living through a level of unprecedented funding cuts to public health. We're also living through an extremely intense period of anti-DEI movements and immigration enforcement that has a direct impact on the health of our communities. In addition, Medicaid, the program that insures, again, nearly half of people in New York City, is facing devastating cuts if this budget reconciliation bill moves forward. We're already seeing some of those impacts at the health department in New York City, and yet we continue to respond and adapt to the federal policies because the cracks in our system are becoming impossible to ignore. Change comes from focusing attention on injustices that have become routine and ordinary and have been made invisible. But making the invisible more visible is how we build power. As always, in the face of crisis, we can find catalysts for change. I believe actually that it's only in times like these, when our social, political, and economic systems are at their most fragile, that transformative change is possible. That doesn't make it easy, and it requires sustained effort and sustained struggle. So let's talk about that. The author and activist Keeanga-Yamahtta Taylor put this observation well in her book, From Black Lives Matter to Black Liberation. She wrote, "Justice is not a natural part of the life cycle of the United States, nor is it a product of evolution. It is always the outcome of struggle." That has certainly been true in my experience. In the face of overwhelming need for structural changes, all any of us can do is work within our sphere of influence. I spent a lot of my career at Brigham and Women's Hospital in Boston alongside your friend, Dr. Eldrin Lewis, who was my attending during residency. We both witnessed some transformative changes take place as a result of sustained struggle. It really began there at the beginning of the summer of 2016. And that was the summer that Alton Sterling and Philando Castile were both murdered by police. The Black Lives Matter movement was gaining a lot of momentum in the face of public outrage. I can't believe that was almost 10 years ago. And the increased national attention on racist police brutality and on racism more broadly created a window of opportunity at Brigham and Women's Hospital. A group of trainees put together a very powerful agenda and put a lot of pressure on the leadership of the hospital to do more and to do better for anti-racism in medicine. The chair of the Department of Medicine at the time was Dr. Joseph Lascalza, who many of you probably know. And he asked me to co-chair a health equity committee for the Department of Medicine. And that was a really powerful experience for me as a young faculty member. Our mandate was to look honestly at racial inequity in patient health outcomes and figure out how to fix it. One of the ideas brought to the committee was an observation by trainees that among the people who were hospitalized with heart failure, it seemed like mostly white patients ended up on the specialty cardiology service, and mostly Black and Brown patients ended up on the general medicine service where I was hospitalist. That observation was the beginning of our cardiology study, which Dr. Lewis and I both worked on. The Health Equity Committee was able to painstakingly get patient data for about 10 years of time at Brigham and Women's to see if the inequities that we thought we were observing were borne out in the data. And no surprise, it was. We found a very clear pattern. About half of Black and Latino people who came to the ER with heart failure symptoms and a primary diagnosis of heart failure ended up on the general medicine service. And that was true only for about a third of white people. Most of the white people ended up on the cardiology service, and that had an impact on the outcomes. The cardiology service had lower rates of readmission, better outpatient follow-up, and a number of other great outcomes. So we, of course, were like, is this real? Is this pattern for sure? We looked at other explanations. We looked at the level of illness and comorbidities. We looked at insurance. We looked at a number of other things. But we found that this was all really a direct product of institutional racism. We also decided to survey ER doctors to figure out kind of what was happening in the ER at the point of triage. And one of the things they told us was that white patients were more likely to advocate for themselves to go to the cardiology service, and that influenced where they sent the patient. So we needed a strategy to interrupt that pattern. We developed an electronic medical record intervention to ask doctors who referred Black and Latino patients with heart failure to general medicine to consider sending them to cardiology instead. And in the background, of course, we were also trying to make heart failure service better on the internal medicine service. It was the first time a best practice alert was used for the explicit purpose of health equity. We've been studying the impact of that alert for the past 3 years. We just had our paper accepted. It's going to be published this summer, so look out very soon for the results of this 3-year best practice alert intervention. I will not give away the results, but we're in a good place. I was also shocked that this was the first time that a best practice alert was being used for health equity. So that tells you a lot about the work that we have to do ahead of us. So that research project really informed this anti-racist agenda for medicine that I co-authored with Bram Wispelwey and published in 2021. It called for institutional responsibility and redress when it comes to racism in healthcare and put forward a framework to do so. We created this framework called the Healing Arc, which builds on the work of Sandy Darity and Kirsten Mullen. They have been doing restorative justice and reparations work for decades, and their framework is acknowledgement, redress, and closure. So we adapted that to healthcare and called it the Healing Arc: acknowledgement, redress, and closure. We've been doing this work with our attempts to remedy institutional racism in treating patients with heart failure, and we included this example, of course, in our agenda for anti-racism in medicine that was published in the Boston Review in the spring of 2021, which also feels like a long time ago. Unfortunately, that publication set off a series of events far more intense than I could have ever anticipated. Telling the truth about our medical systems made me a target. First, there were a series of tweets that said that we were actually racist for doing this work. I got hundreds of emails and text messages calling me racist. We had groups of white supremacists that jammed the phone lines at Brigham and Women's Hospital. I had to have a security escort for a while until things slowed down. And then in early 2022, neo-Nazi groups marched on the lawn of Brigham and Women's Hospital with signs, some of them with my name and picture, and a security detail again came back. But implementing change came at personal risk. Our peer-reviewed and academically rigorous work has continued to make a difference in patients' lives. All of us have a responsibility to care for our patients the best we can. And the fact that those efforts can be met with violence only underscores how important the work is. So I've continued, of course, to keep interrogating how racism shapes our healthcare and health systems in my work as a doctor and as a public health professional. When I joined the New York City Health Department as the inaugural chief medical officer in February 2021, I worked to launch the Coalition to End Racism in Clinical Algorithms, also known as CIRCA. CIRCA is working to prevent the inappropriate inclusion of race and ethnicity in certain medical algorithms. The core issue with some of these algorithms is that they treat race, a socially constructed category, as a biological factor. In doing so, we, in some cases, have programmed racist assumptions about physiological differences into our medical practice and guidelines. CIRCA is trying to end that and ensure equitable care for all patients. We initially focused on 3 priority areas that use algorithms that consider race to the detriment of non-white patients. Those focuses have been EGFR, which, as you know, measures kidney function, pulmonary function test, and vaginal birth after cesarean section risk calculators. We've also added a new focus for race-based antihypertensive prescribing. Each of these, healthcare providers that you see on the slide have partnered with us to remove race from at least one of these algorithms of focus. And I just want to also acknowledge sometimes the pushback we get on this is, well, we shouldn't be, some people think that we're saying stop measuring race or stop collecting race data at all. That is not what we're trying to say. We're saying race and ethnicity data should be collected rigorously, routinely, expansively. But when we use race in clinical algorithms as a proxy for biology, that's when we go off course. In fact, what we did with the best practice alert that I just showed you was we actually used race to advance racial equity, right? So it's still important to use it. It's a question of, are you using race to advance racial equity, or are you using it for some other purpose? So I do want to spend a moment on EGFR. In the clinical algorithm used to calculate EGFR, as you know, there's a Black versus non-Black variable. Oh, that's right. We put this video in. I don't know, is the video going to work? I'm not sure if it's possible. I'll just describe what it is. So PBS put together an episode about the misuse of race in clinical algorithms, and I got to be interviewed as a part of the project. So I was hoping to share a little kind of bit of the video today. And
according to the algorithm that Gregory's doctors used, if Gregory had the same test results but was white, he would have immediately qualified for a kidney transplant evaluation. But why would race be a variable in determining kidney function?
There should be no reason why the physiological function of someone who's Black would look different than the physiological function of someone who's white.
For centuries, Western medicine held that Black people were less sensitive to pain, had lower lung capacity, and denser muscle mass. Science has shown these assertions to be baseless, but that doesn't mean they've been erased from modern medicine.
So the person that you saw in the film is Mr. Gregory Mumford, and he, because of his race, was deprioritized for kidney transplant. And then, of course, when the guidelines changed about calculating EGFR, his risk and wait time for his transplant completely transformed. So by including a variable that dichotomizes patients into Black and non-Black groups, the algorithm again made Black people's kidneys look artificially healthier than everyone else's. We can trace the inclusion of Black race in the EGFR algorithm to an outdated study based on racial stereotypes. It concluded that Black people had greater muscle mass, which accounted for higher kidney function. By allowing that science to inform care, Black patients were getting deprioritized for kidney transplants. That is until federal policy changed. I got to play a small part in this work while I was on the Ways and Means Committee in the House of Representatives. And I shared some of the research that was happening about these inequities in algorithms. Eventually, the use of race-based EGFR equations for nationwide organ procurement transplant was prohibited. Transplant programs have been reviewing their patient data waiting lists with a race-neutral EGFR algorithm, and more than 14,000 Black American kidney patients saw their transplant waiting time change to reflect the true severity of their disease since that change was instituted. Mr. Mumford, who you saw in the videos, wait time went from 3 to 4 years to just a few months. There are many, many more algorithms that use race to calculate wealth when we know there's no scientific reason that race should affect health. It's racism. These are tools we use all the time as clinicians, and changing that practice has to come from us. Great. So just briefly, and I'm about to end and open it up for questions. So hopefully you have your questions ready. In New York, the Coalition to End Racism in Clinical Algorithms has made a big impact. Across all of our participating providers, everyone has either taken race out of their algorithms or a focus or committed to doing so. And this work is ongoing. We're now in our second iteration of CIRCA, and lots of work continues in that space. So with that, I started, of course, talking about the idea that health equity is about working against a long history of peculiar indifference to the suffering of Black and Indigenous people and people of color across our country. We see the consequences of that indifference play out across our country, and it's beyond clear in New York City. Our patients come to us with different experiences and challenges depending on their race, their wealth, the neighborhood they live in, all of which are locked in and often unjustly tied together. Once those patients step through those doors, it's our responsibility to help mitigate the health impacts of an unequal society. But the medical system is not independent of our larger society. The same peculiar indifference to suffering has infected the medical establishment as well. Even still, I see this work as fundamentally hopeful. There's a long history of peculiar indifference, but there's also a long history of resistance, of medical and scientific progress, and of the combination of those two forces. I see it in my work at the health department every day, and I see it in my fellow doctors at this institution. Christiane Hafel is another dear friend of mine, back home in New York City. Especially in these past few months when our systems are so visibly strained, I remember that it's only again in times like these that we can achieve real change. And we know that justice only comes from struggle. So thank you for your attention, and I'm happy to answer any questions.
All right. Thanks so much for your talk. So I'm one of the trainees, and I see a lot of trainees in the room, and we shuttle from city to city, and you know, coming from our hometowns, I think some of us are understanding of the racial inequities and sort of the location specific harm that occurs. But then when we move to another place, we start blank, right? And I think that you moved from, I guess, Boston to New York, and now are holding a really, really important position in New York. And I wanted to get your advice on how to build roots within these new places where we want to affect change, but we may not know where to start.
Oh, it's such a great question. You're right. We are incredibly mobile, for better or for worse, in medicine. And it's also true, of course, that the places that we're living and working and serving have such deep histories that we kind of have to take responsibility for learning and knowing. For me in New York City, I'll just say, you know, I did medical school in Philly, where I'm from, and then Boston for residency, DC, and then in New York City. So being, you know, kind of somewhat rooted in all of these different places in the Northeast, there the patterns are actually super similar. And are, you know, very deeply related to redlining and to historic, you know, and structural racism and those kinds of things. But I think for me, what I always tried to do was remember what I learned from living in Philly and growing up in Philly. And then it's amazing how similar the patterns can be, and helps to kind of guide you about where to start and what to think about. But it was really my public health experience when I moved to Boston that got me much more interested in place-based inequities. And I don't know if you guys have something like this, but for all the interns that start at Brigham, we used to do kind of a couple of days of orientation focused specifically on the history of the community that Brigham is located in. And that was one of the ways that a lot of us started to look at the public health department's maps about health outcomes, understand some of the community organizing that was happening, understand the historic tension between our institution, Brigham and Women's, and the Black community in Roxbury, where Brigham is located. And that there was a long history of conflict. So those were the kinds of things that kind of helped, is like really literally starting, where your feet are standing, and talking to the people who are either the formal or informal kind of historians of those communities to help you understand. I think that's always a good place to start. And that usually spurs a bajillion projects and ideas and collaborations. But it's a very big challenge. Yeah. Mm-hmm.
Michelle, welcome to Stanford. I'm Michelle Berry. I'm sure you're aware of the work that Jean Richardson has done, and the Lancet Commission on reparations that he's trying to get through. I'm curious what your feeling is about, particularly around the financial reparations and where that's going. And I have to applaud you for working in the area that you're working in, really against the tide of what we're seeing in this country.
Thank you, Michelle. Yeah, it is quite a time to be doing this work. I'm so glad you asked about that. I was loosely involved in that commission, and I just saw Jean on Monday in Boston, believe it or not. Mary Bassett is still continuing some of that work. And it was very sad to see how the Lancet Commission ended up just not happening because of a lot of, I would say, kind of elitism and politics, frankly. The Lancet not wanting to take, quote unquote, a kind of political position, even though they commissioned a commission on reparations. So that was fascinating to watch and be involved in. I think ultimately what most of my position on reparations comes from reading the work of Sandy Darity and Kirsten Mullen and Derek Hamilton and others who've really just studied this extensively. For those of you who are really into reading W.B. Du Bois, Black Reconstruction, really, if you read that book and Kirsten Mullen and Sandy Darity's book about reparations, the case is overwhelmingly clear. And it's always been considered something that is not politically feasible. And yet what you see in these books in particular is examples of how reparations have been paid to other groups in the United States in recent history. So it has been done. So from my perspective, I think there's a very clear legal case. And that has been detailed in book after book after book after book by historians and economists and others. Is it politically feasible? I mean, I don't know, was the Civil Rights Act of 1964 feasible? It's one of those things where it's like, well, it's not feasible until it happens. And we've seen that happen many times in our country's history. So, and then ultimately, from my perspective, I think because there's such a clear legal and economic case, and because the racial wealth gap to this day is still as profound as it is, there is a very clear case that the harms from enslavement in this country are still being felt many, many generations later. And then I think what's happening now is we're seeing this expansion in research and our understanding of the relationship between wealth and health, and how much that might be contributing to, for example, the 6 to 7 year life expectancy gap between Black New Yorkers in New York City compared to other groups. So I say all that to say, I'm no expert, but everything that I've read makes me feel that there is a very, very clear legal case for reparations in this country, and it won't be politically feasible till it happens, but it could happen. Yeah. Thank you for asking. And one last thing I'll mention, we did in the New York City Health Department, another project I worked on, we did a white paper in partnership with the Federal Reserve Bank of New York, looking at the relationship between the racial wealth gap and health outcomes in New York. And that white paper makes a number of recommendations, including more rigorous data collection around wealth, and that public health departments actually do that. And it makes a number of policy recommendations as well. So if you're curious about wealth and health outcomes, that white paper it's 2 years old now, but it's a good summary, I would say, of at least the evidence and the literature and the research landscape.
Welcome to Stanford, Dr. Morse.
Thank you.
Wonderful to see you again, Michelle. So I was intrigued by the best practice alert that was used at the Brigham. I was actually in Boston when the uproar occurred, including protests in front of the hospital. It was pretty amazing, shocking. Do you know whether the institution has persevered and is continuing to use that best practice alert? And if so, do you know if other institutions around the country are thinking about adopting that or have adopted that already? And I'm particularly curious to know whether in your capacity now in New York City, whether this is something that you might consider introducing to the consortium that you're working with.
Yeah, thank you for those questions. It's that project was like such a fascinating journey. The general counsel at Brigham and Women's was very involved. And it took a lot of negotiations and conversation between the legal folks and then the kind of, clinicians to come up with something that was workable from a legal perspective. Ultimately, we kind of ended up really pushing the general counsel at Brigham and Women's to talk to civil rights lawyers. And that was kind of the tipping point, because ultimately what they realized and what they kind of agreed to was actually we are in violation of Title VI of the Civil Rights Act now. And we have a peer-reviewed, academically rigorous, published study showing 10 years of data that we're actually not in compliance. And so, in fact, it's in our best interest to do some kind of reparative strategy before we get sued. And so that was kind of the legal hurdle that we had to go through to get this best practice alert to happen, because some people would consider it, well, if this alert only comes up for Black and Latino patients, that's not fair, or there's all these questions that come up when you do something like that. But of course, again, the goal was repair of an existing racial inequity, and that's why we were able to get it through. So it is still ongoing. The research period that we studied, I think it was like officially, the best practice alert officially went into place in winter of 2022, I want to say. And so we have 2 years of data that are going to be published this summer. And my hope is that once that data is published and shows again, like things changed, that will be the kind of proof point that a lot of other institutions need to use tools that, again, are like, it seems so simple, right? It's like, oh my God, 10 years of institutional racism and heart failure care, and all you had to do was put a best practice on it. Like, that's kind of ridiculous, right? And yet it in some ways, it's just that simple. And so I hope that once the results of the study are out, that will be kind of a tipping point for more institutions to consider adopting it, maybe even you guys. I don't know what the equivalent inequities might be here in the patient populations at Stanford, but I think the proof will be in the pudding, and that's when there's going to need to be a call for more places to consider doing something like it. But I think everyone's kind of waiting to see the results. Thank you. Yeah.
Hi, yeah. So you did mention, of course, some of the political realities of things coming up in terms of loss of funding for public health and other things across country. It's just something that is happening right now. Is the New York City, is it working to kind of expand its reach with upcoming potential cuts through like private organizations, other or nonprofit and community-based organizations? And if so, how?
Yeah, it's thanks for getting to the money. It's a real challenge. I think on the one hand, so we are the largest local health department in the country, and do have, I would say, relatively more resources than a lot of other local health departments. For us, about 20% of our budget is federal funding. It's about $600 million out of our $2.5 or so billion budget, which is not nothing. However, we're in a better situation than a lot of other local health departments. Chicago, 80% of their budget is federal funding. Dallas, it's 90%. I was just talking to Dr. Cody about that. So there's a number of big challenges. And I would say relatively New York City is in a good position compared to some other local health departments. But of course, we're doing pretty extensive financial scenario planning right now, because there's certainly a chance that a lot of that money could go away just like that. And there's also, I think what's even a scarier and more likely possibility is that when this budget reconciliation bill passes and we have a federal budget, by September, that in that budget that's passed by law are contingencies that, for example, you can only get the money for your vaccine for children program if you stop collecting race ethnicity data or something like that, right? Those kinds of threats, and that it'll end up being in law and not just executive orders. Right now with the executive orders, we're all playing kind of cat and mouse with the lawyers and things. But I think once it's in law, we're in a much different situation. So we are doing a lot of financial planning, and we are approaching philanthropy to say, like, okay, these are the things that 4 years from now have to still be happening. Like, this cannot go away, period, right? And then for us, and I think this is true in Santa Clara as well, like there are certain things that are legally mandated that we have to do. We have to inspect restaurants. We have to, offer HIV testing. So there's a number of things that we're required to do. And that means that, likely the New York City government and tax base is going to have to fill some of the gap. Otherwise, we're going to be not compliant with the laws that we are supposed to adhere to. So it's going to be very messy and very challenging. And I do hope that philanthropy steps up, but there's no single sector that can fill the gaps that the federal government might leave. It's a lot of money. So, yeah.
Hi.
Hello.
Thank you for a wonderful talk and for the work that you are doing and have done.
Thank you.
I have I think a specific policy question, but and maybe an advocacy question, but in the interest of sort of rooting it as you described in the lived history of a place. So, I'm from a red line suburb in northern New Jersey.
Mm-hmm.
After college, I lived and worked in some of those neighborhoods in Upper Manhattan and in the Bronx with sort of the dramatic wealth-based mortality and race-based mortality gaps.
Mm-hmm.
I lived there not because I was born there, but because it was the only place I could afford to live without asking my parents for help with rent. And eventually, I from them got a no-interest loan that was forgiven to do a post-bac and go to med school. Lots of people don't have that opportunity there, of course.
Mm-hmm.
I never imagined that I would land in a place with possibly even more dramatic wealth inequality and possibly even more billionaires than I saw in New York.
Mm-hmm.
But I did. And now I work at the VA, which is dependent on federal, really 100% for its federal funding, and where withdrawals of funding are not just being advanced along the sort of ideological DEI sort of attacks, but rather as a part of a decades-long campaign to privatize.
Yes.
Despite ample evidence showing that we deliver higher quality, lower cost care with greater patient satisfaction, and despite what you read in the press, better access than the private sector. One thing that gives it, in addition to all of those outcomes, we also run something like a reparations program where for people exposed to Agent Orange,
right,
or other toxic exposures or service-connected disability or with service-connected disabilities, we do our best as a society to make them whole. It's a shame that that's not something we will extend to other groups within the country, but for veterans, to date, we've had a political coalition and will to do it. I think that the roots of that coalition and the roots of that will are built around the larger identity of defining a social class in terms of its relationship to American ideals of freedom, democracy, service, etc. What I'm looking for to do now, and I'm asking your guidance on as a white guy from the suburbs in New Jersey, practicing in a VA, in this highly unequal part of the country, is how do I both honor the traumas that so many, subgroups within the country have faced,
Mhm.
not including like the original owners of the land on which we're sitting.
Mhm.
And while still building a coalition that, if you follow the history of popular movements, transcends barriers of race, class, and so forth. Because my understanding is that in freedom movements, ultimately you need to transcend those barriers to have a movement large and powerful enough to make big change.
Mhm.
Yeah. So that's the question.
Easy, easy. Piece of cake, piece of cake. Yeah, well, this is the right time to be asking that question. And I guess for me, and I interestingly also pick up shifts at the VA back home in Philly every now and then. Yeah, it's a really beautiful experience to actually take care of people at the VA where there's like a full social safety net in so many ways. So, and like, discharge medications is just like not a thing. It's like not a problem. There's so many benefits of working in a, single payer system. So I don't have an easy answer. I certainly for myself have found that my like very nonlinear path has often been I feel particularly either called in or motivated or kind of drawn to a certain either social movement or area of work or community, and then find that it's a match, I guess. And so I think that there is like this inherent, based on your identity, your experience, et cetera, there is this kind of natural matching in a way that happens. And that's where I would say some of my best work has happened. Like I never planned to live and work in Haiti, for example, but I happened to major in French. And then I happened to like start working with Partners in Health. And then I fell into this incredible, project working on healthcare in rural Haiti with community health workers. So I do think that there has to be a bit of serendipity to it. And I think just following where you feel drawn in many ways, like it sounds to me like, a land back movement would be a good one for you to start to like explore and spend some time with. So anyways, I that's not a real answer, but my late mentor, Paul Farmer, used to just talk about how, all of us have to we all have a way and a path of finding kind of our movement, our work, and he called it it's the quest for personal self-efficacy. And he used to write about it, and it just needs to take as long as it takes. So yeah, good luck.
Right, that is the top of the hour. Thank you so much, Dr. Morse, for joining us.
For having me.
Absolutely. And for next week's Grand Rounds, Dr. Chrissy Redhorse and LKS 120. See you then. Have a great week.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.